Hello. Today I'm going to talk about a really interesting review that came out in the JCM last year on the testing, monitoring, and treatment of thyroid dysfunction in pregnancy. The reason being is because we're currently doing some study work about establishing a reference range that is specific to pregnancy for thyroid function for the trust. So a little bit of background from the ATA guidelines. So we know that in pregnancy, it has a profound impact on the thyroid gland. There's a 10% increase in the size of the thyroid during pregnancy in iodine-replete countries, and an even greater size in the increase of the thyroid gland in areas with iodine deficiency. There's also about a 50% increase in T4 and T3, as well as daily iodine requirement. And about 10 to 20% of all pregnant women in the first trimester of pregnancy are positive for TPO antibodies or thyroglobulin. And then 16% of those that are positive for antibodies, but also use thyroid, will then go on to develop a TSH over 4 by the third trimester. And then up to half of those that have TPO thyroglobulin antibody positive status in the first trimester will also develop postpartum thyroiditis. So we know about the physiological changes that you see in pregnancy. In early pregnancy, due to the high levels of HCG, that has a weakly thyrotropic effect on the thyroid gland, and that leads to increased thyroid hormone production and also negatively affect the pituitary. So essentially what you see is decreasing a reduced circulation of TSH from the pituitary gland via the negative feedback. And that's because there is overlap between the beta unit of HCG and TSH, and that's why you see that thyrotropic effect. And this graph shows the difference in levels that you might see with free T4 from conception to birth. You'll see the dip in TSH in the first trimester that goes down due to that thyrotropic effect, and then that stabilizes later on in pregnancy. And then there's also, due to increased estrogen production, you see an increase in thyroglobulin binding globulin TBG, especially in that first week of trimester, which then goes on to stabilize. And as a result, you see a corresponding increase in total T4 with that increased TBG, which also similarly stabilizes a bit later on. And we know that there is a fetal dependency on maternal thyroxine, which explains that physiological adaptation that you see, because in the first week of in the first trimester of pregnancy, the fetal thyroid gland has not yet fully developed. So there is that dependency on maternal thyroxine. And
so Mariana, can you just give us a feel for that blue line? You see how the TSH going down? What is the number?
What's that, sorry?
Well, what is the actual level of TSH at that trough of 10 weeks? Is it like 1 or is it 0.3?
So that's a really interesting question, because later on I'll go through a couple of studies that have found differing ranges depending on things such as ethnicity.
Okay.
So there is no set particular number, and that's kind of one of the hurdles with the studies that are trying to establish a reference range, particularly for TSH in the first trimester.
Okay, but in this graph, I want just a feel for the y-axis because there's no numbers there.
Yeah.
But I mean, okay, I just want to know this. What is it on that at that level roughly?
Well, there are some. I'll move on to it later. But there's one study, for example, that shows that used a reference range of between 0.1 to 0.4. So it's very marginally reduced, but it is less than the non-pregnant reference range essentially. But then it's just that dip that you tend to see in that first trimester. So essentially, the physiological adaptation results in a change in thyroid function test. The increased TBG results in elevation of total T4 and T3 concentration. The first trimester HCG elevation results in a reduced TSH and elevated free T4. You also get the thyroid enlargement that results in an increased serum thyroglobulin and an increased iodine clearance, which results in reduced hormone production in iodine insufficient areas. So in a population which is not necessarily iodine replete, that's quite an important maternal physiological adaptation. So the ATA guidelines essentially recommend assay-specific and trimester-specific reference ranges derived in women without known thyroid disease, with optimal thyroid nutrition and negative thyroid peroxidase antibodies. It's quite a lot of requirements for the reference ranges that they recommend to use. If such pregnancy-specific ranges are not available, they quote a TSH reference range of 0.1 to 4 can be used in early gestation. So that's a little bit, you can see that's marginally lower than the non-pregnant reference range that we currently use. So they've put together the ATA guidelines from 2011, a very helpful algorithm about screening in the first trimester for hypothyroidism. They don't recommend it in all patients, but only in those which are at high risk for developing thyroid dysfunction in pregnancy. And that includes those with, who are over 30, history of thyroid dysfunction or surgery, symptoms of thyroid dysfunction or goiter, thyroid thyroid antibody positivity, type 1 diabetes or other autoimmune disorders, a history of miscarriage or preterm delivery, morbid obesity, infertility, and if they're in an area of known moderate to severe iodine insufficiency. And then based on just the TSH result, that will then reflex free T4 with an algorithmic approach to how to manage any TSHs that are either above 2.5.
These, can I just flag up that these are the old ATA guidelines? You put these down as the 2011 guidelines.
Yes, and they're more
not the more up-to-date ones, which are quite
2017.
different from this. Okay.
So yes, these are the old 2011 ones. The more up-to-date ones are from 2017. And then this is an algorithm which Dr. Agha Shafar has kindly sent me, which is what they use in this trust. And essentially, they advise only checking thyroid function at booking if the patient has a history of thyroid disorders or type 1 or type 2 diabetes, history of pituitary disorder, or history of radiation to the neck. And then they've split it into women on levothyroxine or women not on levothyroxine. And essentially, they do advise that they do not need any follow-up if the TSH is between 0.3 to 2.5, with repeat TFTs at 20 weeks and 28 weeks gestation. And the target TSH here is less than 2.5, and that's as per the ATA guidelines.
The old ATA guidelines, everyone. Sorry, it's Rebecca here. I'm going to flag this up repeatedly because these are, and Rashan knows that is where we haven't got new trust guidelines, but these are old guidelines, old ones.
Old guidelines. So these are based on the old ATA guidelines. And essentially, if the women are not on levothyroxine, and there is a background of Graves' disease or hypothyroidism, then they advise to check the TSH receptor antibodies, which I'll go on to a little bit later on. So that's currently the flow chart that's been put together for use in the test. And that leads me on to this review, which was published last year and gives a...
Before we do that, Neve wants to ask a question.
I'm really sorry, I've got a question, and actually, Rebecca, you can help me. Just in terms of I appreciate that one needs to rationalise, and I'm so sorry, I don't think I've seen I don't think I remember a logarithm from the up-to-date guidelines, but why don't we just do a TSH in everyone at booking?
Because ultimately we're going to overtreat. That's the fundamentals. So and I know, I mean, I think that for overtreat both ends. So I know that the guidance say that 0.1 is the lower end normal, but I had a completely suppressed TSH through my first trimester because I had really awful hyperemesis, and I think that just flagging the numbers will lead to massive overtreatment of people thinking that they're hyperthyroid and not taking a history examination. And also, if you do a TSH, so what's not been picked up on this, so the new guidance says that actually a TSH of 4 is completely normal in the first trimester, because there is this weird grey area between 2.5 and 4. And I think if we start checking everyone, we're going to get lots of people with TSHs of 3.5. And there are many, many people out there, as Roshan shows from the St. Mary's guidance, who will then start treating people who do not have thyroid dysfunction. If you did it on everyone, you'd start treating people with a TSH of 3.5 and saying that they needed thyroxine in pregnancy where there is no evidence that it helps. So I think we need to be really careful that we are not sort of making busy work and anxiety for women when there's no evidence for it.
I hear you. So clinical context as well as what you're saying.
Exactly.
Everything. Okay, thank you.
So yes, so this goes on. So this brings me to this review, which very helpfully has summarized a lot of the evidence out there behind the testing, monitoring, and essentially treatment of thyroid dysfunction in pregnancy. The same authors also released a very recent review covering much of the same content this year. And so what I've done is I've drawn on both of the reviews to summarize each of the take-home messages that they put in the former. So essentially in the first review, they put 8 main take-home messages, which I'll go through and provide the evidence for. And that's split into 2 sections: thyrotoxicosis in pregnancy and hypothyroidism in pregnancy. So the first take-home message that they wrote was that gestational transient thyrotoxicosis and Graves are the most common causes of thyrotoxicosis in pregnancy. Essentially, Graves has a prevalence of 0.4 to 1% before pregnancy and 0.2% during pregnancy, is what they've quoted. And the incidence decreases in the 2nd and 3rd trimesters after a slight increase in the 1st trimester, and that might be due to changes in pregnancy autoimmunity. And the most common cause of non-autoimmune hypothyroidism in the 1st trimester is gestational transient thyrotoxicosis, which occurs in about 2 to 11% of pregnancies, with a higher prevalence quoted in Asian populations. And it's really important to differentiate between these 2 entities because they have a completely different treatment pathway. Painless thyroiditis and subacute thyroiditis are uncommon, and toxic adenoma is also infrequent in pregnancy. So there are quite significant differences between GTT and Graves, even though they both present with a suppressed TSH and a raised T4. GTT can be caused by very high levels or particularly reactive HCG. So as a result, it's usually associated with significant nausea and emesis, and there's no stigmata of Graves. Patients will also not typically recall symptoms of thyrotoxicosis preconception. It's also a transient condition, so will resolve, and treatment with antithyroid drugs is not indicated because it has not been associated with any adverse pregnancy outcomes. In contrast with Graves, you'll see a ratio of T3 to T4 levels higher. They might have a goiter or a thyroid eye disease. TSH receptor antibody will almost invariably be elevated, and the risks associated with Graves in pregnancy are well established, including preeclampsia, pregnancy loss, maternal and fetal congestive heart failure, premature delivery, intrauterine growth restriction, and thyroid storm, as well as body weight being affected. The second take-home message is that although the absolute risk is small, antithyroid drugs can cause congenital malformations. If needed, PTU is preferred to methimazole in the 1st trimester. So the treatment options that they summarize for Graves, essentially if it's subclinical hypothyroidism, in the literature that does not appear to have adverse effects in pregnancy, so it does not warrant treatment. So antithyroid drugs include PTU, which has been associated with a much higher incidence of more severe liver injury, and it can lead to fulminant hepatic failure, although it's very rare. And then carbimazole or methimazole, which along with PTU can increase liver enzymes, which generally tend to normalize after the improvement of thyrotoxicosis or discontinuation of medication. Radioactive iodine ablation is absolutely contraindicated in pregnancy given its teratogenic effects. And in severe cases of Graves, which have not been inadequately controlled, or in patients unable to tolerate antithyroid drugs, thyroidectomy is safest in the second trimester due to the potential risk of teratogenicity from anesthesia in the first trimester, but also the increased risk of preterm delivery in the third trimester. So it's important to consider the teratogenicity of antithyroid medication because they can cross the placenta, and both can increase the risks of congenital malformations, although the overall absolute risk is small. And a number of studies have demonstrated the risk in using antithyroid medication versus no exposure to antithyroid medication. And there was a Danish nationwide registry-based cohort study in over 800,000 live-born children over a decade, which showed that there was a cumulative risk of using both in increasing the risk of congenital malformations versus the background risk of 5.4%, and it was slightly higher in methimazole. And a further extended cohort study, also Danish, in over 1 million children over a 20-year period, showed similar results, slightly lower in PT, as you can see, and there was a background risk of 6.7%. Another study, this was a nationwide Korean cohort study in over 2 million live-born infants, showed that exposure to any antithyroid drug versus no exposure was increased as well, 7.27% versus 5.94%.
Can I ask another question?
Yes, you can. Yeah, those are quite large, those numbers.
Well, I was again going to ask Rebecca, or I find this conversation really difficult, and I would love to know how to play it, in that when you talk to someone about an absolute risk being small, it doesn't, I find that very difficult for a patient to I don't know what that means either, in terms of people wanting to quantify that risk. And I'm just thinking, with that table, does Rebecca actually quantify what the difference is in, I mean, are we supposed to say there's a 2% increase in risk roughly, or what do we say?
Yeah, so my sort of tendency is to say that for all of them, there is a small increased risk, about 2 per 100 people, above the background rate. So I always start off by saying that there is a background rate of congenital malformations, and that there's probably about 2 extra per 100 if you've got a thyroid problem. We know that the drugs do cause malformations, and PTU is probably, carbimazole is probably associated with slightly more severe malformations. The absolute numbers are more or less the same, but the kind of the severity, so the aplasia cutis, where they don't have skin and hair, or the gastrointestinal malformations are reportedly more severe with carbimazole than with PTU, even though the absolute numbers are about the same. But also the uncontrolled thyroid disease is associated with the same increased risk, but again, probably milder than carbimazole. So, because I think that the key bit is to say, if someone's got really rampant grapes, I mean, probably they're unlikely to get pregnant, but what you don't want them to do is to say, stop their 40 of carbimazole because they think that the carbimazole is going to cause a problem, because their thyroid is also going to cause a problem. So my usual risk is to say that the lowest dose that we can have you on is the safest thing, but probably being on something rather than nothing is going to be better for you, and it's going to improve your chance of getting pregnant. It's more or less what I say.
Yes, no, I hear you, and I think I say something very similar, but I think it's, do you see what I mean? It's a bit like HRT and breast cancer. It's the same thing. It's so difficult to say, you know, you say small risk, and then I think, well, what does that mean?
Yeah.
Do you know what I mean?
But if 100 women have a pregnancy and are on carbimazole, they have two of them will be harmed.
Yeah, well, two more than if they weren't. And I think that the key bit, and I think the bit that is often helps, is to say, look, there is a risk, a background risk of there being a malformation. So, so you know, you've got to think that even if you're on this might happen anyway, but probably 2 more people will. Yeah. Than if they
Could you just go back one slide, Mariana? I just want to ask one. Back at this slide, that one. Mm-hmm. So what if you have that PTU, severe liver injury in the mother? Okay, and this is for Rebecca really, because I know that we've recommended that carbimazole is preferred, but that line there That's the mother basically dying.
Yeah. Well, I think probably
it's not acceptable.
You and I have had this conversation many times, and I agree with you. To be honest, I think it's a really difficult conversation, because so you either have a conversation pre-pregnancy, and the other thing that everyone should know is that switching between the drugs in pregnancy doesn't reduce your risk of malformations. Okay, so the idea, and lots of people used to go, oh well, as soon as they're pregnant, then switch them. That doesn't reduce your risk of problems. So don't do that. Once they're on something, just stick with it. And you also want them to be stable. So if you see a woman in clinic and she's on carbimazole and she says, I want to get pregnant in the next 6 months. Well, first of all, she might not get pregnant in the next 6 months, but also you need to then go, well, let's hope that switching you to PTU will keep you stable. And if it doesn't, then you've got worse Graves' disease, blah, blah, blah. So it's a bit of a problem. So it's better to have that conversation early. And say, what your options are. And I think, if someone's on 5 milligrams of carbimazole and has been really, really stable, first of all, can you either say, wait 6 months until we finish your course and then get pregnant, which is the nicest one, or I don't really like switching them to PTU because I find it destabilizes them. And I think that, I've never seen fulminant liver failure, to be fair. But I've also not seen it.
Of course, that's
the
problem.
I think Kath Williamson has.
Has she?
Okay.
At Hammersmith. Yes.
I know she's also a big fan of the not chopping and changing and sticking with one and going through pregnancy.
Yeah. But I also think that, and that's where, if it's a first pregnancy and a first lot of Graves' disease, then often if you lay out all the pros and cons, people are often willing to wait until they've seen if their Graves has gone away. I think the hardest ones are people that get it in between pregnancy, because you can't then give them radioiodine because they've got a small baby, and that you have, so you're then stuck. But personally, I tend to go for carbimazole when you lay it. Most people will, if they're stable on it, will keep with the stability of being on a low dose carbimazole.
Yeah. So carry on, Mariana. Sorry to disturb you there.
No. So yes, as Rebecca said, so exposure to PTU is associated with less severe birth defects. It's not just about the increased incidence associated with each type of antithyroid drug, but it's also the type of congenital malformation that you might see. And carbimazole is generally associated with more severe type defects, such as VSDs, abdominal wall defects, esophageal atresia. And what they've said in the reviews, in the first trimester, PTU is actually recommended for treatment of Graves during organogenesis, in that early developmental phase. Whereas in the second trimester, it's unclear whether to change from PTU to methimazole, because you have to balance that PTU-associated risk of fulminant hepatic failure versus the risk of causing or exacerbating thyroid dysfunction with change, which links into what was just being said about keeping patients on medication if they're stable. So the next take-home message, is overtreatment of thyrotoxicosis should be avoided in pregnancy, as it may lead to fetal hypothyroidism as well as goiter. So monitoring of thyroid function in Graves. The fetal thyroid gland is much more sensitive to antithyroid drugs, which can cross the placenta. And there is one Japanese study which showed that fetal thyroid function may be low even when antithyroid drug treated mothers are euthyroid themselves. And overtreatment of maternal Graves can result in fetal hypothyroidism with a reciprocal increase in fetal TSH and increased risk of fetal goiter. So the ATA guidelines recommend keeping maternal free T4 in the high to normal to mildly elevated range when treating hypothyroidism in pregnancy, and then monitoring thyroid function every 2 to 4 weeks until a stable dose of antithyroid drugs is reached, and then every 4 weeks thereafter. And just a note, thyroid autoimmunity might actually improve in the second trimester, meaning that a lower dose of the drug will be required. Next message is thyroid receptor antibody levels should be checked in early pregnancy in women with a history of active or treated Graves' disease. So maternal antibodies can cross the placenta and lead to fetal hyperthyroidism once the fetal thyroid gland is functional. And they can actually remain elevated for years post-thyroidectomy or radioiodine ablation. So that's something to consider, that even if the patient in the preconception period has had definitive treatment, the maternal antibodies can still remain elevated during their pregnancy. So all pregnant women with active Graves or history of radioiodine ablation should have their serum antibody, their titers measured in the first trimester, and then measured again at 18 to 22 weeks if they're over 3 times the upper limit of the reference range, at which point the fetal thyroid gland is fully matured. And then that will be, if the titer remains above 3 times the upper limit by mid-gestation, then there will be a need for close monitoring of fetal hyperthyroidism or development of a goiter. Next take-home message is that women should wait at least 6 months before conception after radioactive iodine ablation. And preconception counselling in Graves is obviously really important, and any woman of reproductive age diagnosed with Graves should be counselled given the potential adverse effects associated with anti-thyroid medication and the risk of uncontrolled thyrotoxicosis in pregnancy. It may be, as previously mentioned, PT might be preferred in the preconception setting during early development in the first trimester, even though that there is that risk of fulminant hepatic failure. And the other thing to consider is definitive therapy with thyroidectomy or radioiodine ablation, which can be considered prior to conception in women who prefer to avoid antithyroid drugs. However, as mentioned, pregnancy will need to be avoided for 6 months after radioiodine ablation. And it's also worth noting that in those cases, there can be a worsening of Graves' thyroid eye disease. And then moving on to hypothyroidism in pregnancy. Adequate thyroid hormone is critical for normal fetal development, and there is an increase in thyroid hormone requirements in pregnancy. So the risks of overt hypothyroidism have been well recognized across quite a few studies in pregnancy. One as early as 1988, where they found a small n number, only 28 pregnancies that were detected from a 10-year period, and they identified increased risks of preeclampsia and placental abruption, leading to low birth weight as well as fetal death. And in the 1990s, there was another study where there was a cohort of about 68 hypothyroid patients, and they recognized increased risk of gestational hypertension, also low birth weight, and also preterm delivery. In 2000, they identified in over 9,000 singleton pregnancies, there was a reported 4.4-fold increase in the risk of fetal death in women with a TSH of over 6 in the second trimester, compared to mothers who were euthyroid. And then again, another study showed that there was an increased risk of fetal loss and premature delivery. And then finally, in 2013, there was a US national cohort study in over 200,000 pregnancies. And what they found is that untreated maternal overt hypothyroidism led to preeclampsia, gestational diabetes, preterm birth, cesarean section, as well as admission to neonatal ITU. So it's quite well documented, the risks of overt hypothyroidism in pregnancy. So that's with obstetric outcomes. Thinking about neurodevelopmental outcomes, so the adverse effect of maternal thyroid hyperfunction was first reported in the 1970s. As the fetal thyroid gland doesn't mature until 18 gestation, thyroid hormone is necessary for early development, as the source for the baby comes entirely from transplacental passage. And there was a case control study back in the 90s of children of hypothyroid mothers where there was a median TSH of 13.2, and they were found to have a 4-point lower IQ at 7 to 9 years of age versus children of euthyroid mothers who had a median PSH of 1.4. So next take-home message is treatment of subclinical maternal hypothyroidism is actually controversial. And there is increasing evidence for associations between maternal thyroid hypofunction and adverse pregnancy and childhood neurodevelopmental outcomes. But with subclinical hypothyroidism, it's just a little less clear-cut than overt hypothyroidism. And this is just a summary of a number of the studies which they referred to. And as you can see, there are some observational studies which did not show any significant association between subclinical hypothyroidism in the mother and miscarriage or pregnancy loss, prematurity or preterm birth, gestational hypertension, gestational diabetes, preeclampsia. However, there was a meta-analysis and a systematic review which did show an increased risk of miscarriage and pregnancy loss. Multiple other studies which did reveal an association with prematurity and preterm birth, and these are across the years. And most recently, there was quite a large study which demonstrated an increased risk of prematurity. And there are also links with neonatal death or respiratory distress syndrome as well, and also placental abruption. So there is conflicting evidence between some studies, observational studies, which have not shown an association between adverse outcome, and quite a few others which have. And again, with child neurodevelopmental outcomes, there was a prospective cohort study of over 3,000 child-mother pairs. And what they found was that both low and high maternal levels of free T4 in early pregnancy were associated with a lower child IQ versus normal levels of maternal free T4. However, a couple of years later in 2018, there was a longitudinal study based in the UK in over 4,000 mother-child pairs, which didn't show any significant association between maternal levels of TSH or free T4 levels in the first trimester. There was no significant association between thyroid status and the test scores of children between the age of 54 months to 15 years. And then also in 2018, there was quite a large meta-analysis of 26 studies, which did show significant associations between maternal subclinical hypothyroidism and various measures of child intellectual disability, including low IQ, language delay, or global delay. So again, there's also a little bit of conflicting evidence when it comes to child neurodevelopmental outcomes in subclinical hypothyroidism. And using levothyroxine treatment in subclinical hypothyroidism is also quite a controversial topic, with numerous studies again showing quite a lot of conflicting evidence. So one study found in Iranian pregnant women that there was no difference observed in preterm delivery between treated versus untreated women, although when they did a sensitivity analysis of women with a baseline TSH of 4 to 10, they did find that actually treatment did decrease preterm delivery risk. By a large meta-analysis of 7 cohort studies and 6 RCTs from 2 years ago showed almost a 20% decrease in the risk of pregnancy loss in women with subclinical hypothyroidism who received levothyroxine. However, they also showed that there was an increased risk of preterm labor. And then there was another RCT which showed no significant differences in child neurodevelopmental scores between thyroxine-treated women versus placebo. And then finally, the CAT study showed that thyroxine did not result in significant differences in mean child IQ. And a follow-up study by the same group found that at 9 years of age for these same children, there was no difference in IQ between children of treated versus untreated mothers. So thyroxine treatment in subclinical hypothyroidism remains controversial. There's a lot of the data from the RCTs is quite limited, but they suggest that thyroxine treatment in subclinical hypothyroidism, especially when the TSH is over 4, might decrease the risk of preterm delivery and pregnancy loss when initiated in early pregnancy. The main limitation with this data is that the thyroxine treatment was not necessarily initiated in the first trimester. And we know that that's when when the fetus needs it for neurodevelopmental outcome, when they don't have their own source. So although no notable benefit for child neurodevelopmental outcomes demonstrated, the studies are limited by late initiation of therapy for gestation. So further RCTs are needed to determine the effect of thyroxine on adverse obstetric and child neurodevelopmental outcomes when treatment is actually initiated in the first trimester, when it really matters. So next message is that women with hypothyroidism should be treated with thyroxine for a goal TSH of less than 2.5 in pregnancy. And this is in reference to what the ATA guidelines have recommended. So thyroxine monotherapy is recommended in overt hypothyroidism to prevent obstetric complications and child neurodevelopmental outcomes, which has been clearly demonstrated in a number of studies. And the ATA guidelines favor treatment of maternal subclinical hypothyroidism with TSH values of over 4 if TPO antibodies are positive, and TSH of over 10 if their TPO antibodies are negative. On the other hand, other guidelines only recommend therapy if free T4 is known. So it's a little bit of a gray area when it comes to subclinical hypothyroidism. When thyroxine treatment is warranted, the goal serum TSH is less than 2.5. And most women on thyroxine preconception will require about 20 to 30% increase in dose to maintain euthyroidism due to the estrogen-induced rise in TBG. And then after delivery, their dose can be decreased back to their pre-pregnancy dose with repeat TSH testing in about 6 weeks.
I'm really going to ask another question.
There's another question, and then we need to move on a bit because.
Oh no! Stop! It's fine.
Let's ask a question quickly.
Why is it TPO antibody positive more than 4 and negative? Why is there the difference in TSH? I think TSH more than 10 sounds so high. Do you know what I mean? I was surprised at that. What's the rationale for whether or not they're TPO antibody positive or not?
So there's absolutely no rationale behind the TPO antibodies, and none of this mentions the tablet trial, which shows that TPO antibody, there is no good evidence behind TPO antibodies, and as with everything, we should just stop measuring them. But it gives a lot for, you've got to remember that a lot of these are American studies, and fertility doctors do love giving a little bit of thyroxine because it fixes people's miscarriage, which it doesn't, but it feels like they're doing something.
I hear you.
So we should not do it. And the reason that it's that we have this big conflicting thing is that original paper, the Lazarus paper, which looks at it was a terrible paper. They had to recruit people with different, they couldn't get enough recruits at the beginning. So it's an awful study, but it's made such a difference, which said that a TSH above 10 was they compared a TSH above 10 with a TSH of less than 2.5 and said that there was a difference. And so there was this gap between 2.5 and 10, which has been left in a sort of blank kind of unknown box for 20 years. And so people make up stuff in the middle of that, basically. So
sorry to ask.
Yes, that makes complete sense.
Yeah.
Have you got many slides to go?
No, that's pretty, just 2 or 3 slides left now.
Okay.
So that's basically, that summarizes the review.
Yeah.
So that leads us on to pregnancy reference ranges. So essentially that leaves us with a need essentially for reference ranges which are trimester specific, population specific, but also assay specific as well. And there was one study in over 4,000 Chinese pregnant women which showed a downward shift of the serum TSH distribution at about 7 to 12 weeks gestation. And what they found is that they quoted reference intervals between 0.14 to 4.87 during the first trimester, but specifically a bit lower between 7 to 12 weeks of gestation, 0.1 to 4.34. Their reference intervals quoted were higher than those reported in Europe and the US. nearer to values reported in India and Spain, lower than those in the UAE. So there is a little bit of discrepancy in reference intervals quoted based on country, which is quite interesting. Iodine status is obviously really important. This just summarizes the changes you'll see in pregnancy. Spot urinary iodine concentration can be used to assess iodine status. Severe iodine deficiency in pregnancy can cause maternal hypothyroidism and has been associated with increased risks of miscarriage, premature birth, stillbirth, and the effects of mild to moderate iodine deficiency on child neurodevelopment is still unclear. And then very briefly, thyroid autoimmunity, TPO thyroglobulin antibody positivity in pregnant women is estimated between 5 to 14% and 3 to 18%. And actually, meta-analyses of thyroid women in pregnancy show about 4 times increased risk of recurrent miscarriage associated with thyroid autoimmunity. And there seems to be an additive or synergistic effect on miscarriage and prematurity when it's combined with maternal subclinical hypothyroidism. And RCTs have explored the benefits of thyroxine treatment in euthyroid TPO antibody positive pregnant women, but there hasn't really been a significant effect demonstrated. So finally, that leads me to highlight the pregnancy reference ranges study that is being led by Rebecca that we've been conducting. And essentially, we aim to establish trimester-specific reference ranges for thyroid axis hormones in pregnancy for the trust. And also, we'd like to determine urinary iodine concentrations in the pregnant population in London. And it's quite useful that we have a very ethnically diverse population that we're recruiting samples for. So we've been collecting trimester-specific pseudo-anonymized collection of blood plus or minus paired urine samples in an ethnically diverse cohort of pregnant women. And the main inclusion criteria is that it's a single pregnancy, and we've been excluding anyone with a current or previous history of thyroid disorder, thyroid medication, as well as if they're unable to participate due to other factors. So the main key points that are quite useful to think about, quite interesting to think about, are the need to establish trimester-specific reference ranges for managing and monitoring thyroid disease in pregnancy, given the number of the amount of evidence and that's been covered. And also it leads us to think, are there any other analytes of value that require reference ranges to be established in pregnancy? The evidence for associated risks with maternal subclinical hypothyroidism remains conflicting, and treatment with thyroxine is also controversial in that particular area. Thyroid autoimmunity and the role of thyroid peroxidase antibodies is also an interesting topic for discussion in pregnancy as well. That's it.
Thank you.
Yes, thank you. That was super thorough, Mariana.
And
I learned a lot. Thank you.
Dr. Martin?
No, I'm so sorry. I feel like I've been so prepared. It's just so interesting, isn't it? I'm so sorry. We see it all the time. Do you know what I mean? So.
Any last word, Rebecca?
No. Mariana's been amazing at helping with the study, which is forever my, my cross to bear. But yeah, it's we'll get there one day. But the main thing is just, I think we make a lot of busy work for ourselves, which I think it's it provokes a lot of anxiety in women, and I think we need to not do that.
Yeah, I agree.
Yes,
I think
agree.
it's not just maternal medicine; it's the whole of endocrinology does that.
Yeah.
I think we find ourselves saying that a bit in the pituitary.
Oh yeah,
but visual fields in pregnancy are a big deal if you don't need to have them. Do you know what I mean? It's all these things where you medicalise someone, I think.
Yeah.
Thank you, Mariana. That was fabulous.
Thank you, Mariana.
Thank
you.